Morning, ladies and gentlemen. It's a pleasure for us to organize a event like this. Actually, this is organized by the Sri Lanka Stroke Association, along with the base hospital Horana, regarding the update on ischemic strokes, acute stroke thrombolysis. So we are very proud that as a base hospital, as the first base hospital in the country to start acute stroke thrombolysis. So we had several patients being thrombolized, and we had good results, and there are some bad results as well, but anyway, overall they are doing well. So today I would like to welcome the president of the Stroke Association, Dr. Harsha Gunasekara, and he is the consultant neurologist, Sri Jayawardhanapura General Hospital, and I welcome Dr. T. Prathipan, the consultant radiologist from Base Hospital Horana, and I welcome the other consultant physician, Dr. Vigneswaran from Base Hospital Horana, present here, and all the doctors of the medical unit and the PCU, as well as all the doctors from the other units who are interested on acute stroke thrombolysis. And at the same time, I welcome all the viewers through online who has joined to this event through the Zoom app we have provided. And I welcome the sponsors, the Boringa, who sponsored this event. So first of all, to start with this program, I will invite Dr. T. Prathipan to talk on the radiological appearance of acute strokes and its mimics. Thank you very much.
Good morning, everybody. I am Dr. Prathipan. I am today a consultant radiologist. I am going to discuss about the imaging of stroke. Stroke can be divided into ischemic stroke, hemorrhagic stroke, and transient ischemic attack. Ischemic stroke can be further divided into according to the arterial supply of the brain, middle cerebral artery territory infarction, anterior cerebral artery territory infarction, posterior cerebral artery territory infarction, and lacunar infarction. Here, middle cerebral artery territory infarction is the most important one because it involves the motor cortex, and lacunar infarction caused by the obstruction of the perforator branches which supply the periventricular region, including internal capsule. So, motor function can be affected by lacunar infarction also. Now, I will show some images. Here you can see hypodense area in the right parietal region with sulcal effacement and mass effect. We can say minimal midline shift and the right lateral ventricular compression. This is the features of the acute middle cerebral artery territory infarction. Then we can see here hypodense area with the sulcal effacement in the medial aspect of the right anterior parietal and the frontal lobe. This is due to the right anterior cerebral artery territory infarction. Here we can see the similar changes in the left posterior parietal and occipital region compatible with left posterior cerebral artery territory infarction. Here you can see the hypodense area in the region of the posterior limb of the internal capsule and the basal ganglia. This is due to the lacunar infarction. And now I will show image of the hemorrhagic infarction. In contrast to hypodense areas, hemorrhagic infarction will show the hyperdense areas, that is white color, which involve the caudate nucleus, the hypothalamus, and the anterior limb of the internal capsule. This is due to the hemorrhagic infarction. Here another example. We can see the left middle cerebral artery territory infarctive features with some few hyperdense areas. Here you can clearly see here and here. Then this is due to the hemorrhagic infarction of the left middle cerebral artery territory. It is important here because in thrombolysis setting we have to first see for the infarctive features, and we have to exclude the hemorrhage, as intracranial hemorrhage is contraindication for the thrombolysis. So in images, first we have to looking for the infarctive features, then we have to looking for the hemorrhagic features to exclude the things. Then I will go moving to the CT changes immediately after stroke. That is, some subtle changes occurs in the CT changes occurs immediately after stroke. That is including the dense middle cerebral artery sign, altered gray-white matter differentiation, and minimal sulcal effacement. Three radiological signs occur immediately after stroke. This is example for the dense middle cerebral artery sign. You can see here there is a cord-like hyperdense area seen along the left middle cerebral artery. This is due to the thrombosis of the middle cerebral artery. We nicely seen as a left MCA sign, that is middle cerebral artery sign, dense MCA sign. In this patient, we can see sulcal effacement and altered corticomedullary demarcation in the right parietal region, that is MCA territory region. This is due to the acute stroke of the right middle cerebral artery territory. This is also important to differentiate between the acute and chronic stroke, because if sometime with the unreliable history like that, patient is unconscious or altered behavior like that, can be present with the old infarction. Here we can see the old infarction hypodense area, but instead of sulcal effacement, we can see the volume loss. Prominent sulca here, and this lateral ventricle is prominent. So this is due to the old infarction. He is not the candidate for the thrombolysis. Now I will move to the stroke mimics, that is including the tumor-like diffuse glioma, infection-like encephalomyelitis, and toxic metabolic disorders. I will show some images of that. Yeah. This slide shows the slightly altered mass effect, that is altered sulcal effacement seen in the left parietal region, and it is crossing the midline, involve the medial aspect of the right cerebral hemisphere as well, and nodular hyperdense area. This is end up as the diffuse glioma. Differentiation features is like here, that is stroke changes won't cross the midline. Then this patient is, this slide shows the hypodense area with sulcal effacement in the posterior temporal region bilaterally. This is due to the herpes encephalomyelitis. The differentiation features include this presenting bilateral changes, as well as posterior temporal region is not commonplace for the infarction. This one is carbon monoxide poisoning, that is called the globus pallidus sign. We can see small hypodense areas bilaterally in the basal ganglia, that is in the globus pallidus, that is called the globus pallidus sign, with minimal edema also there in this region. We can see the sulcal effacement due to the edema in both sides. Hepatic encephalopathy usually not cause any specific CT features, only causing cerebral edema. You can see this is generalized edema, generalized alkali basement seen in this image. This is non-patient with hepatic encephalopathy, but in this slide show the normal CT. For the comparison, I put both. This patient with a hypertensive patient, I am showing here that hypodense area in the bilateral, posteroparital and the occipital region, particularly in the white matter. This is due to the PRESS syndrome, that is called posterior reversible encephalopathy syndrome. That is a reversible condition associated with hypertension. Now I move into the some hi-fi images. That is called, first one is the CT perfusion study. It is actually enabled differentiation of the salvageable ischemic brain tissue called pneumora from irreversibly damaged infarcted tissue called infarcted core. So if you are not knowing the timing of the stroke, if you do the CT perfusion study, if pneumora is more, that patient will benefit from the thrombolysis. But if it is pneumora is less, that patient very unlikely to benefit from the thrombolysis. Actually, it is inferior to MRI quality-wise, but can be done quickly. Technical-wise, we need at least 64 slice CT and proper software, so we are unable to do it here. But we can try it in the NHSL. They are having the 64 slice CT for cardiac CT images there. Limitations include small infarcted core. Small lacunar infarction can be missed, and poor cardiac flow will deteriorate the study. I am showing one image. Because of the softwares, they are putting the color maps in this side. This is in the left-hand side. We are saying the purple color one is the infarcted tissue, including the pneumora and the infarcted core. In the right-hand side, that is in the small purple areas are infarcted core. So here, fair amount of pneumora is here. This patient will benefit from the thrombolysis. Actually easy to interpret if it is proper software is available. Then I will move to the MRI images. MRI images for the stroke patients, we used to do the diffusion weighted images and ADC map. Acute stroke, that is 1 to 7 days, diffusion weighted shows high signal and ADC map shows low signal. Subacute state, that is 1 to 3 weeks, diffusion weighted high signal and ADC map shows normalization, that is called pseudo normalization. Chronic one, that is more than 3 week stroke, will show low signal images in diffusion weighted and high signal images in ADC maps. For less than 24 hours stroke, we call the early hyperacute stage, that is less than 6 hours. Here also diffusion weighted high signal and ADC low signal, but T2 and flare images are normal. But late hyperacute 6 to 24 hours, T2, particularly flare images, show minimal increased signal intensity. Acute stroke, that is earlier we show that more than 24 hours will show the T2 and flare clearly high signal. Then I will show some images. This is 27-year-old patient with the sudden left hemiparesis 2 hours after the onset. Here we can see the flare images show almost normal, and diffusion weighted images show high signal area in the right parietal region, that is MCA territory region, and ADC map shows low signal area. This is 6 hours after the onset, same patient, shows hypersignal area with alkali basement in the flare images, show that flare images start to show the changes. And diffusion weighted show clearly high signal areas, and ADC map shows low signal areas. This slide shows difference between the acute and subacute stroke. Here that cerebellar region, right cerebellar hemisphere shows high signal in diffusion weighted, low signal in ADC map, and slightly high signal in T2 weighted images in the acute stroke. In subacute stroke, high signal in diffusion weighted, but normalization of ADC map and clear high signal areas in the T2 weighted images. This image shows the right MCA territory infarction of T2 images of acute stroke, showing hypersignal area with sulcal effacement. Now I move into the intracranial calcification. In our setup, first we have to looking for the finding of infarction. then we have to exclude the hemorrhage. So it is important to know the common intracranial calcification because it can stimulate the hemorrhage. Here we can see the basal ganglia calcification, bilateral hyperdense areas in the basal ganglia. You can see the stipple areas of hyperdensity and no surrounding edema. This is due to the basal ganglia calcification. Particularly if it is one side only, sometimes it is difficult to differentiate the hemorrhage and calcification. Other feature is the measuring the density. If it is more than 100 HU, that is belong to the calcification. Less than 100 HU belong to the hemorrhage. This is calcification along the false cerebri. That is also another common place for the intracranial calcification. Other one, calcification along the tentorium cerebelli, that is covering above the cerebellum. So we can see along the calcific areas along that. Then other one is the pineal gland calcification. Pineal gland seen in the roof of the third ventricle in midline. So we can see as a calcified area in the pineal gland. So in summary, for the location, when you are seeing the stroke patients with the hyperdense areas, first see for the location, then looking for the surrounding edema. If it is location is suggestive of the calcification and no surrounding edema, we can pass it as a calcification. Now I move into the some clinical scenario like that. You try to say whether that is whether you go for the thrombolysis or not. This patient develops sudden onset of right-sided hemiparesis. What do you think? Yeah, you can see here hypodense area involving the internal capsule and the basal ganglial region and the caudate nucleus. This is due to the lacunar infarction. Image-wise is suitable for thrombolysis. This is actually more than 6 hours, but it is image-wise, I told, that's why. This patient found unconscious and immediately admitted. What do you think about this? You will go for the thrombolysis or not? Actually, this one showing the hypodense areas in the left middle cerebral artery territory with sulcal effacement due to the acute infarction, but I didn't see any features of hemorrhage. Here we can see as a small hyperdense areas in the medial aspect, that is due to the reperfusion. We measure the density, so this patient is suitable for the thrombolysis if it is clinically tally with that. This patient having altered behavior. You can see as a hyperdense area with the surrounding edema. This is due to the intracranial hemorrhage. This patient have the altered behavior. What do you think about this? Yeah, this is hypodense lesion with some nodular hyperdense area, not much surrounding edema. Then we did the contrast study. That nodular area shows enhancement. This is end up in astrocytoma. This patient develops sudden onset of left-sided hemiplegia. What do you think of this one? This patient showing the hypodense area with sulcal effacement compatible with the right MCA territory infarction, but you can see here clear hyperdense area within the infarcted area. This is due to the hemorrhagic transformation. So this is not suitable candidate for the thrombolysis. Then I show some MRI images for the interest of that stroke mimics. This is that first one I showed you that carbon monoxide poisoning. Here showing clear hypersignal area in the basal ganglia region. That is carbon monoxide poisoning. And this one is that earlier I showed that Press syndrome that shows the hypersignal area in the white matter, particularly in the posterolateral region and the occipital region. This is due to the Press syndrome. And this patient having the fever and altered behavior, you can see the hyposignal area in the T1 weighted images, contrast enhancement showing contrast enhancement, and T2 weighted shows hypersignal area. This is due to the herpes encephalitis. Thank you very much. Do you have any questions? This one. This one.
Thrombolysis.
Image wise, yeah, because
Because a large occupy more than 2/3.
Yeah.
Yeah.
Actually, if
I
you do
would
the
not-
seat, sorry,
Yeah, I would not thrombolize that. It's
uh,
very large.
very large because of the.
There, sometimes what happens is the timing.
Mhm.
Patients reporting may be not accurate.
Actually, when I doing the foreign training, this type of patients, we are doing the CT perfusion study in the Monash
Perfusion, and then
University.
that's correct. Yeah.
Then numerize more, they are going with
Yeah.
that. If it is large infarction, if it is numerize less, they are prefer
That's
to
right.
stay without
Yes.
doing anything.
Yeah.
Not only the thrombolysis, they are
Yeah,
doing
in our setup,
intracranial, some intervention as well. So just that clotting retrieval like that also they are doing.
Right.
What is the minimum time you can see the radiological changes?
That is not, sorry, not every patient's, every films we can see the changes, but after 3 hours like that, we can see the dense MCS, I know, minimal sulcal effacement, but actually,
Even 1 or 2 hours?
if it is depending on the patient, because some patients only will show those changes, not every patient, depending on the size of the infarction and the thrombus of the metacerebral artery. Some metacerebral artery partially thrombosed, we won't see the MCA sign at all, and if it is small infarction, we won't see
So
the
then
sulcal
how do you
effacement.
decide on, say if patient comes immediately 10-15 minutes or half an hour, we do a CT, it's 1 hour, so it comes to 1 hour to your hand.
Yeah.
So how do you...
that is you have to decide on clinical wise. If
Clinical
it, not
wise.
not hemorrhage, and even no, you don't see any infarctive features, I think you have to decide to go with the
Clinical.
thrombolysis.
Right.
Because most of the changes we see in
So
our
you
department,
tell that you decide in your in our site, ne?
side, if it
Okay.
exclude the hemorrhage first, and if it is less than 2 hours or
Right.
like that, very unlikely to see the changes if it
Right.
is less than 2 hours.
Right.
If it is 6 hours, sometime.
Yes.
Any clinical, we have to see. Yeah.
Mm. Yes.
Yeah, that is because no changes mean that is very acute. If we don't have the MRI or CT perfusion study, so better we will go for the thrombolysis in that setup.
Okay, thank you.
Welcome.
Thank you very much, Pradeepan. Having a good idea on the radiological appearance of strokes and its mimics. Now we can move on to the next topic. I invite Dr. Harsha Gunasekara, the consultant neurologist of Sri Jayawardenepura Hospital and the president of the Sri Lanka Stroke Association, to talk on the update on thrombolysis for ischemic strokes. So I invite Dr. Harsha Gunasekara to the dais.
So thank you, Dr. Priyantha, for that introduction and also for arranging this program and actually to initiate treatment in a base hospital for the first time in the country, and we are very thankful to the team of physicians who initiated this, led by Dr. Jayalath, and we hope that it will be continued and this will result in more patients can access the treatment. So since initially we started with the teaching hospitals, now we are going to the provincial general and some district general, and so first base hospital. So we are very proud of you for initiating this and giving us a chance to give you an update. If you take phases of acute stroke treatment, you can see in this the different phases. So in our country, the pre-hospital phase is now being, it was not very well developed, but now with the availability of 199 North Source area ambulance service, our pre-hospital phase is getting developed, and one area we are focusing by the National Stroke Association is to train the emergency medical teams to identify stroke quickly and bring them to the correct hospital. So we are providing some training for them. We have planned that already with the Suvasaria Foundation. So pre-hospital phase in other countries is very well developed. That's one area we can focus on when trying to get the patients quickly to hospitals. So that is the phase from the symptom onset to the hospital door. Then you get the hyperacute phase. So hyperacute phase, that is the phase from door to the first tower. That's a very important phase where you can really save time to treat the patient on time. Then you get the acute phase, the first 24 hours after 1 hour to the first 24 hours after admission, and then the post-acute phase, 24 to 72 hours after admission. So these are the time periods. Of course, the care doesn't end there, but these are the patients, the most important time after the stroke. So in my talk, probably we'll be discussing only the first 3 of these. So the stroke management extends beyond this up to the post-acute phase, and then, of course, thereafter the rehabilitation and also prophylaxis. So these are the areas that you need to focus on. So the pre-hospital phase is very important, minimizing the delays. Then the hyperacute phase is the time we'll concentrate on reperfusion these patients initially, and then reducing the neurological disability. And also in the acute phase, now there's development of other reperfusion methods, including thrombectomy. So that's very important. And also managing the patient from all aspects, which can deteriorate the patient's outcome. So if we take the global burden, these are the latest data which shows the statistics. So I won't waste too much time on this. 12.2 million new strokes for a year, with 1 stroke occurring every 3 seconds. So one area you can concentrate here is up to 80% of the strokes and also heart attacks happen in people with low or moderate cardiovascular risk. So that's very important. And also 89% of global stroke deaths occur in countries like ours, low and low middle income countries. So we need to really improve our care to bring these the numbers down and figures better. So what data do we have from Sri Lanka? We don't have much national data, particularly no incidence data at all. So there have been some community studies which shows an incidence of 9 to 10 per 1,000 population, so about 1% of strokes. But there was data from the clinical registry which covered 6 hospitals, teaching hospitals. This was in 2017, which shows these data. So 2 points in this I like to highlight is presentation to the hospital within 3 hours. I think that time the 3 hours was the time interval, and only 16%, and thrombolized only in 3%. But these figures are now improved. We don't have the latest data from this. These figures are now much better. So more than 85% of strokes we see are ischemic, and so we are in our catchment area where they are potentially treatable, as opposed to the 15% of hemorrhagic strokes. So some of these may be TIAs, but sometimes we need to go according to the clinical state of the patient and treat them. So, as we always tell, stroke is a medical emergency, and the phase is that time is brain, because as Dr. Pradeepan showed you on the radiological slides, our aim is to save this ischemic penumbra. So you get the co-infarct here at the middle, and you get the surrounding large ischemic penumbra. So this is what we are trying to save by reperfusion treatment. So, sorry, I'll go back to that. So that's the degree of neuronal loss that we see after acute stroke. So every 30 seconds, every second 32,000, then every minute 1.9 million, and every hour 120 billion. And per stroke about 1.2 billion cells die. So that's why we need to be time conscious in treating these patients to minimize the damage. So protection of the ischemic penumbra depends on a rapid diagnosis, rapid access to imaging, and rapid initiation of treatment. So I will not go through this, which also shows the time advantage. As you can see, with the occlusion, there is a central core, then there's a peripheral area of penumbra, which has a lowest cerebral blood flow. The infarcted core has the lowest cerebral blood flow, then the penumbral zone, which has a reduced blood flow, and the normal brain. So with time, what happens? The time axis shows, with time the penumbra gets smaller and smaller, and the infarction gets bigger and bigger. So our catchment area is this area of first 4.5 hours. So this is what happens if you don't treat. The initial CT will be normal. You may not see the infarcted core, and with time the CT starts changing. So if you see this in a real life situation, this I captured from one of our patients, 65-year-old patient. This patient presented to a suburban private hospital with acute left-sided weakness for 2 hours. You can see the first CT is quite normal, as Dr. Pradeepan showed. So these are ideal CT for thrombolizing a patient. So that patient was not treated there, and they did a MRI, and it shows a large infarction. So, and then the subsequent CT show the damage is completed. So the patient should be treated within the correct time interval. So thrombolysis, currently the only licensed drug is alteplase. As you know, the mechanism is a plasminogen activator, which converts plasminogen to plasmin, and which then converts fibrinogen to fibrin and dissolve the clot through the action of thrombin. So there are other, and you may be aware of the other fibrinolytic drugs, the streptokinase, which we use for myocardial infarction, and also tinectipase currently, which is used for myocardial infarction, is not licensed for stroke at the moment. There are special situations where tinectipase is used, but at the moment it is not licensed for treatment. So what is the expected benefit and risk of treatment? So this is a simplified diagram which shows is, if you take a cohort of 100 patients treated, so the 32 will benefit, and there will be 3 and there will be 3 patients who will have the complications and 1 death. So these are obviously due to the hemorrhages, and there will be no major change in the rest. So you may expect a non-improvement in your patients. So, but the benefit is, because of the benefit, we treat the patients if they are eligible. So it's important that you explain, like I saw in your protocols, there is a nice informed consent form that you tell the patient the benefits and risks of treatment. So again, it shows the time benefit. So closer to the line, it's alteplase verse, so you have to be always away from it. So with time, what happens is the benefits get lower and lower. So you can see these are the initial results from the NINDS trial. With the time interval getting longer, the benefits gets less, and the rate of complications will go up. So the most important thing in thrombolizing is minimizing the door to needle time. So this is the standard chart which is given in most of the guidelines. So from the arrival time for the emergency treatment unit or your primary care unit, then quick assessments and doing the investigations, then informing the on-call team. So initially the first point of contact would be the emergency doctors. From there, the medical team here will take over. Then the CT scan is initiated. So standard door to imaging time should be less than 25 minutes. Then the results interpreted and then treated. So it's not a guideline that you have to take 1 hour, but earlier the better. So the shorter the time is the better. So how can we optimize the door to needle times? So your attempt should be at least in your 50% of your cases. If you can attempt a time, door to needle time, we can't sometimes have it in all patients, that we can't achieve less than 60 minutes time, but at least in your 50% of your patients treated, you should be trying to achieve this. So if you take the pathway in the treatment of the acute ischemic stroke from the time of the arrival in the emergency, so there are 2 parallel pathways, so probably you should initiate. So that will save you time. So in the assessing the patient, I think the nursing staff does a lot, doing the vital signs, checking the blood pressure, saturations, temperature, and doing a capillary blood glucose, sending the important blood tests including the INR, blood counts, electrolyte panel, electrolytes and the renal functions, cardiac markers, coagulation tests, and also ECG. So these things are arranged, and then at the same time the on-call medical team or the stroke team is informed, which the doctors will do a quick assessment of the patient and do a NIHSS. So this is very important. We do that before we deciding on treatment. Then at the same time you arrange the CT scan, which should be read immediately, and I think your staff is very well equipped with that. I heard that you all have a good WhatsApp group where you communicate quickly with the radiology staff, and you arrive at a decision whether to treat the patients or not. So, the four important step is diagnosis, assessment, CT interpretation, and decision to treat. So, all this should be through a protocol that you use. That's very important that you use this for standardizing the treatment. So, step 1 is a rapid diagnosis. So, most of the time we use a stroke scale rather than doing a thorough examination and history. So, FAST is the very important scale that we introduce even to the emergency teams and general public to identify stroke. So, we have posters of this we will be giving you all to display in the clinics and for the patients who visit the clinics, and actually the association will be doing a sticker in all 3 languages so that they can paste it on the clinic book on the side, so that the patients will know that this message that when the signs and symptoms appear to a family member or a nearby patient, that the patient should be taken to the so this is an old poster, but here we have changed this to incorporate the source area hotline number, that is 1990, and we'll be distributing that with the new leaflets that we are giving you today. So the other thing you can tell your patient is source area has done an app, so it's available to download on your mobile phones, so the patients can have it with them. Very easy for them to, if you call through the app, the ambulance can quickly locate the patient where it's, rather than telling the directions and all that. So very important that if you tell the patient to download their 1990 app on their smartphones. So the next important thing in the initial assessment is the time of onset. So that's our treatment depends on the time of onset. So there should be a clear time of onset, less than 4.5 hours. So here you have to be mindful about the wake up strokes. So the patients, in these cases, we might have to ask for the patient's time where they were last known to be well. So in a patient who had a wake up stroke, it is the time that the patient went to bed. Sometimes we see patients, the patient is found fallen, so the family members didn't know, and then when they saw the patient after a while, they found that the patient has a weakness. So again, we have to take the patient's time as the time where the patient was last seen well. So this scale, most of you all will be aware, these are one we usually use in the emergency setup. It's called the Rossier, or recognition of stroke in the emergency room. So here it helps more than also to identify the stroke and also to rule out a stroke mimic. So there are negative marking for the first 2 points. That is, there's a loss of consciousness or syncope and a seizure activity. It goes minus, whereas all the others are positive. Those are the typical signs of a stroke: asymmetrical facial weakness, arm weakness, leg weakness, speech disturbance, and visual field defects. So if you have a positive score in this, you don't have to even calculate. The patient is very likely to be a stroke, but not if it's a negative. So Dr. Pradeepan went through all the stroke mimics, the radiological. So you can see the stroke mimics you will see here, but most of these you can clinically diagnose, and of course, the hemorrhagic strokes will be picking up, hemorrhagic complications will be picked up on CT scans. You have to be careful of isodense subdurals, which can be sometimes missed, but usually you should be able to exclude most of these on your clinical assessment. So then the assessments. So very important that we record the GCS, the National Institute of Health Stroke Scale. Blood glucose is the most essential step, because hypoglycemia is a very common stroke mimic. Established IV access, and then we send the investigations, and then transfer the patient to the CT. So NIHS, I know initially you may have issues with this on time. It's they are in your protocol, so you are familiar with this. But if you want if the beginners want to do a training, it's available free online. So you can just go to this website, and you can do your online training free, and you can get a certification also on it. So so the score should be based on the patient's response, but not the observer's interpretation to get an accurate score. So the usual time is by a trained person. It can be done in less than 10 minutes. So these are the 11 items of analysis in these scores. So it's very important when you are looking for drift that you ask the patient to raise the arm and count to 10, so that to see whether there are subtle drifts. So otherwise your scores may change. So very important that you do in your examination. So CT brain interpretation is the most important thing. Always we may not get radiology help, but most of the time the consultant physician should be able to give the nod whether to treat or not. So the most important thing is for us to see a normal CT scan. So if you see a normal CT scan, that's the best state to treat these patients. The patient has a weakness. You may see very subtle early signs of ischemia. Even in this you can see, sometimes you can see the very early signs of ischemia. So this patient with the right side weakness, so left-sided weakness. So but if there's a well-established infarct, probably you may not treat it. You can see it's quite hypodense here. So this may be the patient's timing is inaccurate. So most of the times if you give patients TPA, there can be a hemorrhagic transformation. So particularly in the case if the infarction is large. So we'll have to discuss the imaging if there is a radiological help, but I would not thrombolize a patient like this. You can see it's quite hypodense, so it's well established infarction is there, and usually we will not thrombolize. Then the early signs of ischemia, as was discussed in the lecture, the hyperdense middle cerebral artery sign is one, if you can see it, but it should be only unilateral for it to be significant. And also you might see other subtle changes like this, the basal ganglia hyperdensities, which will still not be a contraindication, but still it will be indication, it will be not a contraindication to treat. So you can obtain your own CT training through this Angels Initiative website, which I will be discussing at the next talk. So you can go through all the CT readings by just doing that training online. So decision to treat is the most important thing, your step. So here the eligibility criteria is diagnosis of acute ischemic stroke with a measurable neurological deficit. So we say around NIHS is 4 or more. Onset of within 4.5 hours from the time of treatment, age more than 8 years, and exclusion of all other contraindications. So this is a list of contraindications which is there in your protocol. So probably with time you get used to this. So we are mostly worried about major head traumas or intracranial and spinal surgeries within 3 months. Any history of previous intracranial hemorrhage is a contraindication. Doesn't matter what time. So if there's any history of previous ICH, it's a contraindication. Then symptoms of suggestion of subarachnoid, structural GI malignancy with GI bleeds, intracranial neoplasms, AVMs or aneurysms, infective endocarditis, aortic arch dissection. Then the coagulopathies, if the INR is more than 1.7, APTT more than 40, or platelet count less than 100,000. So hemorrhage is obvious contraindication, or well-defined infarction. Arterial puncture of a non-compressible vessel has been done, and intracranial arterial dissections, use of low molecular weight heparins, current use of, now direct antithrombin inhibitors are now being used in the country. Some drugs are already registered, so be careful. There can be issues when the patient is on these drugs. If you take patients over the 80 years of age, there are more strict criteria, so you will exclude the very severe strokes and oral anticoagulant use regardless of the INR, and history of diabetes and prior ischemic stroke. So we need to exclude them. So the other important thing is the blood pressure management. As you know, there are blood pressure targets following a stroke. So this chart gives you for patients who are given thrombolytics, the target should be 185, 110 prior to treatment, and 180, 105, that is 5 degrees less, 5 millimeter mercury less for the rest of the 24 hours. So non-thrombolized patients, you can allow the pressure to be untreated to prevent the worsening of the infarction unless there is a coexistent hypertensive emergency. So in ICH, the targets is 160, 100, and subarachnoid is 140, 90. So important to remember those targets. So 185, 110 is our target to thrombolize patients. So when you're confronted with the patient in the eligible patient but with a high pressure, you have to use a parenteral drug, not oral drugs to treat. So the best option is labetalol. You give a 10 milligram IV bolus. It can be given over 1 to 2 minutes and repeat only once if there's no response. After that, you can give an infusion. So it's a quite a fast acting drug, and it can be used unless the patient has a more than a first degree heart block, there is no otherwise absolute contraindication. The alternative is hydralazine, but hydralazine problem is the onset of action is slower than labetalol. So administration, you know the dose, 0.9 milligram per kilogram, maximum dose is 90. Most of the time, you don't have to sort of waste time on calculating, because we can incorporate a dosage chart to your protocol. So it's easy that you can have a chart like this, where you can quickly, according to the patient's weight, this has been pre-calculated for you. You can calculate the bolus and the infusion dose that you have to give. So the best option is to give the bolus immediately after reading the CT. So that's the best time. Most of the time it's given within the CT department itself to preserve time, waste from shifting the patient back to the emergency. So if you have the facility, you can monitor in the ICU, HDU or stroke units, but we can safely do monitoring in the wards itself. The more important thing is delay in certain procedures, like placement of nasogastric tubes, indwelling catheters, CV lines, intramuscular injections, intraarterial pressure catheters should not be placed in patients who are prepared for thrombolysis. And no antiplatelet drug should be given, no anticoagulant medication, and no non-steroidal anti-inflammatory drugs in the first 24 hours. So if your patient needs anticoagulation for some reason that you have detected atrial fibrillation, most of the time you may do a repeat CT to see whether the patient has any hemorrhagic transformation before starting these. So the after treatment is very important that you monitor the patient in the first 24 hours very carefully. So the blood pressure target is systolic 180 and diastolic 105. Temperature should be monitored. Neuro observation should be done carefully to see whether the patient has any complications. So most of the time we have these charts in the wards and the high dependence units to alert the monitoring pathway. So that's the usual guidelines. For the first 2 hours every 15 minutes, then the next 6 hours every 30 minutes, and then hourly for the next 18 hours. So we always be prepared to manage. All the complications are very rare, but always be prepared to identify them and manage. So the hemorrhagic complications are the most distressing ones, both intracranial and extracranial, and of course the non-hemorrhagic, the most important thing is angioedema, which is again quite rare. So the different types of hemorrhagic changes you can see is most commonly is the hemorrhagic infarction, which has two types. The type 1 is small petechial hemorrhages. I show you the images along the infarctal margin, and otherwise you get the type 2 where they are confluent petechial hemorrhages. Then the parenchymal hemorrhages, which are more what we call disabling to the patient. You can get a hematoma affecting less than 30% of the infarcted area with mass effect, or the PH2 is the worst type, where there is a large hemorrhage, and also there may be hemorrhages beyond the infarcted area. So these are the four. That just a minor hemorrhagic change you can see within the infarcted zone. Here these are more confluent hemorrhage, and these are large hemorrhage. So symptomatic ICH, most of the time you need to do the clotting screens and inform, repeat them. If the patient has any deterioration of the neurological deficit, you need to repeat the CT scans. So get the transfusion specialist involved to correct the coagulopathy, and neurosurgical intervention may be needed in patients with large parenchymal hemorrhages. So orolingual angioedema is a very rare complication, but you need to have this in your protocol to treat the patients if there is any possibility of developing this. Risk can be higher in patients who are on concurrent ACE inhibitors. So, so I won't go through the management protocol. It's there in the guidelines, and we can include that in the protocol also, so that in any emergency we can treat the patients. Endovascular treatment is now available for treatment at NHSL. In patients with large vessel occlusions, that is involving the internal carotid or the middle cerebral M1 segment, is currently the criteria to treat these patients within the 8 hours time onset with a pre-stroke MRS, that is the modified ranking scale of the patient, that is either no symptoms or mild disability, and with a measurable neurological deficit with a NIHS of 6. So benefit in other vascular territories is not sure, particularly in the posterior cerebral territory, and the vertebrobasilar territory is not still evidence based. So there is intraarterial thrombolysis as well. The first treatment always should be giving the patient the intravenous thrombolysis before thinking of the other procedures like thrombectomy and intra-arterial thrombolysis. So only situation practically we see is in patients who get post-operative stroke. So you can't use thrombolysis. So the most of these patients may have to be referred for intra-arterial thrombolysis or thrombectomy. So if you take the summarize the comprehensive stroke management pathway. So the diagnosis is the most important, excluding the mimics, and confirm the diagnosis. Doing the CT to rule out a bleed, and then assess the severity of the patient. See whether there is a large ischemic territory or a small ischemic territory, more than 1/3 or less than 1/3. And if the CT is eligible, then you exclude the other contraindications, and then go on to treat the patient. Now, if it's a center of excellence, large vessel occlusions usually are referred for endovascular treatment, but in our setup, we always thrombolize them first. So that's how you proceed. So both large vessel and small vessel strokes, first option of treatment is giving alteplase, and then those who don't respond, we can refer for endovascular treatment. So if you see, I just show you 2 videos of trying to preserve door to needle time here, which is given in this website. So these actually probably we are not geared up for this much because of the our emergency services are still not this developed. Usually what they do in other countries is they notify the hospital before bringing the patient, so that the hospitals are geared to quickly receive the patient and do the assessments and the scans immediately. So here what it shows is the patient being received by the emergency doctors, then again the transfer is the handover is done to the emergency team, and then again the it will show that the consultant assessment is done after that, which there's another handover which takes a lot of time for the patients to be treated. So is the audio available on this?
She's 75 years of age. She was at home, collapsed.
So I think your setup, I think this may be better because, of course, within hours, physicians can see the patient, but out of hours, I think the emergency doctors will, with the stroke team, will assess the patient and do the needful and get consultant's opinion for treatment. So, more than 35 minutes lapsed when the patient is, so low to CT time is too much. What are your average time to get a CT? That's probably, do we have it near the PCU? So that's very good. Yeah, that's a very good setup. So here the shorter method, there's pre-notification, and then most of the assessments have been done by the emergency team, and the patient is sent to the CT scan much earlier.
False positive, hypertensive, glucose 6.2, no medical history, no allergies, no meds. What's the side there? Right hand side hemiplegia. Walk behind me. Is he going to get squashed?
So I think we are far from this, achieving this. So most of the emergency room work is done in the CT department itself, and even these patients are recommended to be treated once the CT is read then and there. So first thing is in this thing is to get our emergency teams trained, and also establish a system of pre-notification, which is quite impractical in our setup at the moment. So I know in some hospitals for myocardial infarction they have a system in place, but not for stroke at the moment. So it's also important to maintain your stroke registries, as I saw what Dr. Jayalat showed me, that you all maintain your records well. So you can join one of the databases, which I'll show you in the next talk. So you can maintain your data accurately. That's a very important recommendation in the current guidelines, that you maintain a database of your patients. So finally, the 10 pearls, which we have always highlighted this in our talks. So treatment should be initiated within the time window, admit directly to hospital with a thrombolysis facility. So that's very important, so that patient doesn't waste time going to the GP and other treatment centers. So blood glucose is the most important investigation, and a normal CT. So those things should clearly tell you that the patient could be treated. Then don't do unnecessary NG intubations, catheters in the immediate state. control the blood pressure. Always use your protocol. Monitor and anticipate and monitor for complications and side effects, and always attempt a dot needle time of less than 60 minutes because the time is brain. So any questions we can discuss now, your practical issues we have faced during your treatment. Yeah. Yeah, only issue is that during the procedure, if there is any trauma, because when you are inserting and then you are thrombolizing, it can bleed. No? Whereas once you treat, according to the half-life of altiplase, the maximum effect of bleeding will be there for 90 minutes, and therefore after that it subsides. So you can safely do it later. Particularly urinary catheterization you can do, but NG tube better delay a bit. You can keep the patient on drips and do it little later. So doing it earlier may carry a risk if there is some traumatization during the insertion, and then you might cause a bleed. So if you can wait for the NG tube at least, because the effect of the hemorrhagic effect will subside gradually. So the initial 90 minutes is the time that according to the half-life of the drug. It may be different for other thrombolytic agents, but altiplase is a very short half-life. So that's why we had to give it as an infusion.
After thrombolysis, how long the risk of bleeding persist into the brain and all?
Yeah, so if you take the intracranial hemorrhages, they usually appear within the first 24 hours. So not immediately after thrombolysis. So that's why you have to, that 24-hour period of monitoring is very important. You may do a CT immediately and say everything is well, but you might get a hemorrhage within 12 hours or 18 hours. So first 24 hours is the time you might see the hemorrhagic complications on the intracranial hemorrhagic complications. So
time for repeat CTs after
24 hours.
If indicated, we don't routinely repeat CTs. So if there's an indication where there is a patient change of clinical status, you can do. But if you are using anticoagulation, maybe that it's worthwhile doing, because antiplatelet drugs can be given even during a hemorrhagic transformation. But anticoagulants should not be given. So if you are having any suspicion, it's better always to repeat a CT.
Having dual antiplatelet therapy, is it a contraindication for thrombolysis or not?
You mean pre-treatment?
Pre-treatment.
No.
No.
That's allowed now. Actually, that's there in the guidelines. So that's not a contraindication. But always we tell not to give loading doses to the patient, which usually what we do in stroke. So no loading doses should be given. But if the patient has been on dual antiplatelet, that's not even on warfarin. If the INR is less than 1.7, we can give. We have practical problems when cath lab procedures. So patients loaded with aspirin 300, clopidogrel 300, and then heparin, and the patient get a stroke after the. So the patient is in hospital. After the procedure is done, stenting is done, patient has a stroke, they call us. So what we do is we quickly check all the clotting times, activated clotting time, the APTT, and we see how safe is to. So we have to use your discretion and give. So if the ACT is high or the APTT is high, we usually they use conventional heparin, so we can give protamine and reverse, and then we have done a few like that without any problem. So there has been no bleed because your time interval is very safe. The patient is before you within an hour, unless they take time to inform. So it's very easy. Those patients are readily available for treatment. But according to the guidelines, patients treated with enoxaparin is a contraindication. So that is there in patients with MI and stroke. Sometimes what happens is they receive enoxaparin in the first 3 days, and then the patient develops a stroke, you can't treat them. Any other questions from the team? There's no guideline saying that. It's just consultant's interpretation. So if a consult physician can definitely interpret, a neurologist can interpret. So if you have the services at hand, you can always obtain it, or if there are any suspicion. Yes. Any suspicion? So as Dr. Prathipan showed, the mimics, hemorrhage mimics like calcifications, always get, if you're not sure if they are asymmetrical, you can get, I also most of the time WhatsApp the images and then get their opinion before treating.
So up to 4.5 hours is the best time.
At the moment, the guidelines is up to 4, but there have been certain
beyond,
trials beyond that,
beyond
6
that?
hours, but it's not still,
Not recommended.
it will be not according to the standard guidelines, so it's better. So we usually follow the ASA, AHA guideline. 2019 was the last update, so we'll have to wait and see. It might lengthen, but problem is most of the time we don't have the CT perfusion. So if you go for those time intervals, you need those CT perfusion studies and.
So generally, actually, the patients are a bit confused when telling the story about this thing, weaknesses and so on. So they generally sometimes comes out with, yesterday also had this. And
that's right.
Yeah, today also in the morning.
So be very careful.
Oh yes, and some neurological radiculopathy patients also.
Yeah.
That is sometimes very difficult to even assess the patient.
Yes. So those are mainly the sensory symptoms. So it's so what we tell is there should be a measurable neurological deficit which is not rapidly improving also. But it's sometimes difficult. Sometimes we see patients improving at the beginning, but after admission they deteriorate. So you think the patient is a TIA, but then they have continued to get a stroke. So those are practical issues which we need advanced imaging really if you are treating them.
The earlier RIND, that concept was there 1 hour, when they improve within 1 hour.
Yeah.
Completely improved. Anything weak.
Yeah, so that is again
not indicated.
There's no indication for treatment if the patient has completely improved.
TIA is also not.
So any questions? If so we'll just go through the have you web page minimize kara web page we had from issues in sorry. Yeah, so we'll just see whether we'll get the audience participation in this. So we'll go for a So any questions I would welcome till we get this going. So this is actually I would invite you to register in this website. It is called the Angels Initiation, so you can go through your, I'll just go back to the So that's the website. So you can register your hospital, and then all of the whole team can undergo training through this. So you can have a common password, and so that's the website. So you have different training available on this. So you can go for CT training. You can do the emergency services have their own training, and there's training for especially for nurses, that is stroke nurse e-learning, that is a separate module. So at all levels of staff they can go through their training. So what we are doing is on this decision making, so there are case simulations, so we'll just see some ups. Can you get the other? Okay, yeah, oh, sorry. The other cases.
Male, 70 years old, sudden onset of speech impairment and right-sided weakness 2 hours ago.
So you can
Previous hypertension and dyslipidemia.
So they give you like a short scenario like this, and then for you to deal with the case. So you click start here, and then the case will load up. I think there is an app also on this, but I think it will be too slow if you do on a mobile. So better you can if you do it on your. So here you can get the patient. So you have the case details. So you can go to the. We had a problem in this history here, so we can ask the patient different questions. Then you can go to the physical examination. So you can check what are the areas you want to check. And you can get the important things. So in a acute stroke, what we mainly need is to know the glucose level. So it gives you the current glucose level, and we need to know the saturation. So it will tell you, and the blood pressure. So that's okay for treatment. So so you can do the heart rate also and check. Can put the ECG monitor. So looks the patient has an atrial fibrillation. So then you can request the test the patient. So you can quickly go through the lab test. So you check for the complete blood count.
Test ordered.
Usually do you all wait for the result? Dr. Priyantha, platelet counts, do you wait or you treat? Yeah, you are okay to treat retrospective unless there is obvious bleeding history or there is a suspicion that you need to check the count before you, so there you can get the patient as a normal count. So then other important is the coagulation.
Coagulation tests have been requested to the lab.
So it will run a countdown timer to see how much time you have taken to arrive at the decision. And so these are okay. INR is within the range. So then I think, yeah, imaging is the next thing.
Head CT scan underway.
So the registration for this site is given according to the hospital center. So you can have a common password for you for base hospital Horana, and then all can undergo the training. So the CT is running. You can see it's quite. So these is this a contraindication? Actually, we need to ask what's that. So sometimes sometimes you might think about SH. So this is just the tentorial. So that's important that, yeah, it's calcification. Yeah. So it's quite a normal CT. So probably most of the other investigations are additional. So you need to not. Then you go for the, of course the information has to be done, so which teams you want to call, so stroke team.
The stroke unit has been called.
Then you go to the interventions. So interventions, again you can select what you want to do. If there's so some cases you might get a low oxygen, so you might have to go for supplemental oxygen. The guideline is if the saturation is less than 94, that you need to give supplemental oxygen. Then other managements if it's needed, but most of the time you can go straight to treatment actually. So here you can check if the patient is having hypertension, then you need to treat accordingly by, I think, what are the other drugs you can use in emergency situation? I don't think we have in our setup anything other than labetalol, hydralazine. We don't have, IV nicardipine is also used in the West, but we don't have it. So we'll have to stick to labetalol. Yes. GTN is not the best option, but most ICUs, HDUs use it because it can worsen the cerebral edema. So GTN is not the best option in acute stroke. So medication, you just straight away you scroll down and select your altiplase, and then you can get a breakdown of your case and go to an analysis of what you have done. So I think we didn't do it so it gives you a assessment on what to, so it's the most likely. So I think we didn't do the full run through here. We'll have to go through the whole thing. You can get your feedback. Yeah. Yeah, I think we'll have to so I think it's a little difficult for us to do the whole thing here. If you can just I'll show you the other areas you can use in this website. Sorry. So you can do your CT training using this also. So that's the training that you have to do. So that's where you can just click here and you can start using the CT trainings too. Yeah, so I think it's just self-learning here. I'll just show the other areas of this website where you can. So there is a Acute stage. There are some presentations also in this. You can. So these are actually just self-learning that you can do. Just go to the then I think there are some important modules for the emergency nurses to follow in this. That is also quite a good resource for certification of nurses, so they can go through the individual training sessions. Have the nursing staff had any training? We can actually arrange that no, yeah. So it's a separate area. We mainly concentrate on the rehab training actually. So we have the neurology unit team, so they do the strokes. So all the physicians refer the yeah, from the emergency itself we yes.
All right.
Any other questions from the doctors actually who see patients? Any questions you have come? Oh,
So a patient coming with a TIA,
yeah.
and we manage as a TIA, but patient develop again the disability worsens. Is it an
Yeah,
indication for
so
giving thrombolytics?
yes, so it depends on the time interval. So what if he
Within
goes
4 and
beyond 4.5 hours?
Yes.
That will be again, then you need to repeat your CT. So those are the situations where you have a risk of having complications, because the onset of the stroke may be the time that he developed the TIA. So those are the situations where you need perfusion imaging, checking the perfusion defects, and then treating the patients, which is not available even in our setup. Yeah, those patients I think is better not to take a risk unless your patient deteriorates within the time interval, and still you can treat if the CT is okay. But most of the time what happens is the patient deteriorates after the time window. So oops, I think I already logged in here, I think. Any other questions? Any questions from the nursing staff? You can. So I heard that you have had few complications. Did you have to transfer them or? Yeah. Yeah. So sometimes it happens. You stick to all the criteria, but sometimes the patient bleeds. So that we have had 1 or 2 cases like that. So. So if you are starting the patient on anticoagulation, again, you have to be watchful. As we do, you repeat a CT. If there is a infarct, it's better for you to wait for 7 to 10 days and then start. Maintain the patient on antiplatelets and then start, because we have had one experience with patient who was started on anticoagulation early, who developed a hemorrhage. Fortunately, that patient recovered, immediate surgery done and recovered, but there is always a risk. So if you start anticoagulation, better, and with the infarct, sometimes even after post-thrombolysis, you might see an infarct, although the patient has improved. So, so 1 week at least, that's safe. Sorry about this, it's giving us a little problems, I think. can I go through some questions with just to recap what we have done with the audience? Sorry. Is there another presentation here? Or? Oh, yeah. Yeah, just a few revision MCQs for you to see with your. Have you all had a chance of going through the ASN webinars? I don't know whether that is organized by the Association of Sri Lankan Neurologists. I don't know whether do you all get the links to join, and it's all on the website. So you can go to asn.lk and register and watch all our past webinars. It's there on the, and now there's a YouTube channel as well. So what is this? What is the most important initial assessment in a patient with acute stroke symptom? So these with respect to thrombolysis. What would you do? Yeah. Of course, all these are important, but as the patient comes, what is the first thing you need to? Yeah. Yeah, glucose, obviously. So that's very important stroke mimic. You should not treat the patient if your capillary blood glucose is less than 50. So you need to correct and see whether the patient improves. So which of the following is not a contraindication to give TPA? Out of the 5. Yeah, so it's not a contraindication. That's actually indication to give. If you see a nice unilateral hyperdense middle cerebral artery, that signifies a large vessel occlusion. Of course, these patients ideally should be referred for thrombectomy, but in your setting and our setting, we can first do thrombolysis. So hygromas you should never give. Established infarctions better avoid. Then any space occupying lesion, any aneurysm or any history you should not give. Blood pressure target for the first 24 hours after thrombolysis. Yeah. What is it? Huh? Number? Correct, yeah. So 180, 105. So all the others are the other targets. 140, 90 subarachnoid, these ICH. These before thrombolysis and these were non-thrombolized. Following procedure can be safely done within 90 minutes of IV thrombolysis. Which is the correct one? Yeah, only venipuncture is safe. So I mean, it depends. Like if you can anticipate a bleeding in a compressible site, then it's okay. So we have sometimes patients, as I told, after cardiac catheterization. So still we have a arterial puncture, but we can thrombolize them. So if there's any hemorrhage, they can control with local measures. We haven't had major problems. This one, 52-year-old man who was receiving treatment for a non-ST evaluation MI developed right-sided weakness and dysphagia. NCCT brain is normal. Which of the following would be a contraindication? Or can the patient be treated? Yeah. Is the patient eligible for thrombolysis, or what is the contraindication? Huh? Yeah, only issue here is the use of low molecular weight heparin. So according to the current guideline, they say it's a risk if the patient has used it within the last 24 hours. So that would be a risk here, but not use of antiplatelet drugs, and not acute even STEMI you can thrombolize if there's a stroke according to the new guideline. So you can give straight away without giving tenecteplase, you can give alteplase for the patient if the patient's other criteria are fulfilling. It's not a contraindication unless the obvious LV aneurysm or some other contraindication is there where you can't treat. So use of heparin is an issue here, but especially low molecular weight heparins. I think if this is changed to a novel anticoagulant, I think that would be the same scenario. If the patient is on rivaroxaban, dabigatran, or apixaban, I think these are all associated with a risk. So there are trials which have shown that it is safe, but I think it's not still. Yeah. If the patient has a stroke. Yes. So CT is normal, yes. But only thing, your ECG is always done and your cardiac enzymes are done. So your contraindications, there would be if you sort of think of anything which could cause a bleed. So if you have excluded things like aortic dissection, those are the things we have to think of in patient come with very. So otherwise coexistent acute coronary and a stroke is not a contraindication. Sorry? Yes. So alteplase is okay for, only thing the doses are different. What we use for stroke is a smaller dose, but they use usually tenecteplase. So yeah. No. Obviously the stroke. That's a very good question, because if you give, so tenecteplase is still not licensed, and you can't give that. So yeah, until tenecteplase is licensed, we have to use alteplase in that situation, because the current trial dose for tenecteplase for a stroke is 0.25 per kg. How much do you use for myocardial infarction? Yeah, I know, exactly. No, for what is the tenecteplase dose you all use for MI, STEMI? Yeah. So yeah. So 0.5. So stroke is 2.25. So even if you are giving tenecteplase, it will be a lower dose. Myocardial infarction. Because if you give the full dose, it will be causing bleeding from the stroke. Yes. So whatever the benefit is subtherapeutic, but you can't take the higher dose really.
Sometimes strokes mimics the heart, ECG changes, mimics heart, cardiac events.
Yes. Ischemic changes. Yes. Yeah. Yeah. Sometimes you might get marginal elevation of troponin and as well. Yes. So, are you okay? Shall we? Any other clarifications or? So, thank you for organizing this and thank you for coming today. And so we'll be doing some further training on for the nurses, and also as I told Dr. Jayalath, we'll be preparing the new protocol and we'll give it to you all so that you can use that as a standard when you are treating. Thank you very much.
Before conclusion, I just want to tell the medical officers that now the people are aware of some injection after the strokes, so they come for it. And they do not know what time frame they stick to, but they are asking for it. So if the medical or the hospital team is prepared to provide it, they are happy to take it. So when most of these patients come to all these patients come to the emergency department, or the PCU, through the triage. So if you can pick them up from at the time when they arrive the triage. So this patient has got a stroke and is within the time frame of thrombolysis. So please inform immediately to the PCU doctors, and they will, I think, better to initiate by ordering a CT scan immediately and doing the blood glucose, ECG, and after and at the same time inform the medical team. So then we can cut down the door to needle time. So that is an important part in this management of acute strokes. So from there onward, we can proceed with that. So that is a very important message. Actually, should go to the PCU. You can convey it to the others, and most of the PCU doctors are not here. Some are here, no? Some are here, yeah. PCU, yeah, PCU. So when somebody coming with a 3 or 2 hours of stroke, so please attend to that patient with even leaving the other patients alone. I mean, they are non-urgent patients.
I think it's quite time saving.
Time saving. Blood glucose, CT. CT. So call the doctor. That's enough. That's enough. Yeah. So if we can give this tenecteplase bolus dose in the PCU, that will be the further beneficial. Alteplase. Yeah, that's what I want to tell you. I think if we are going ahead with the acute stroke thrombolysis, these are the measures we have to take to improve the quality. Okay, thank you.